everybody, welcome to class. Today we're going to go and cover a little bit of chapter 1 and give you more of a background on what epidemiology is and the history of epidemiology. How did we get here? And so to start, I want to talk about, again, what is epidemiology? So we know that epidemiology is really looking at patterns of diseases in populations. And so we want to understand what are the health problems, where are they coming from, who they're affecting. And the very first epidemiologists, as I'll discuss later in the lecture, really were about just recording observations, just seeing what happened. And a lot of what epidemiologists continue to do is that we do observational studies. We're not necessarily always intervening, though that has become part of epidemiology as well. And so what we want to do is understand what are the causes of the disease, what are the patterns, and use that to recommend how we can prevent or eliminate negative health outcomes. And we deal with diseases that really affect local populations, very hyperlocal populations, counties, states, countries, continents, and diseases that are considered endemic, epidemic, or pandemic. And I'll discuss those terms again later in the lecture. Epidemiology is considered a multidisciplinary field. Multidisciplinary means that we draw from other disciplines, other areas of specialty to generate what we know, the information. And so we're pulling from medical and biological sciences, social and behavioral sciences, as well as biostatistics, but we also interact with people in law, for example, when we're developing health policy based on the science of epidemiology. Epidemiology or epidemiologists often define themselves either by the exposure that they're interested in. So people may be environmental epidemiologists, they're interested in the effects of the environment on multiple different health outcomes, or diet on multiple health outcomes. They may define themselves as disease specific. So I'm a cancer epidemiologist or a perinatal epidemiologist, and your interest is a specific disease outcome and all the myriad exposures or risk factors for that disease. And then there's another category, sort of broadly, that's interested in doing program evaluation and looking at how programs and policies are or are not effective in reducing adverse health outcomes. But before we get to what we do now, let's talk about where we came from. And so to think about where epidemiology developed and how it developed, we have to go back in time and understand where the study in the field of medicine in general came from. And so if we look back at classical antiquity, for example, it was Hippocrates who first suggested that there might be environmental factors as the cause of disease rather than not praying efficiently or appropriately to different gods, for example. And so maybe these disease outbreaks might have to do with things like air and water and place. A little bit later, there was the pandemic of Black Death. This is the plague, the bubonic plague. This was a huge significance for epidemiology because it was the beginning of understanding how diseases spread through populations. And we now believe that it was a bacterial infection and it was transmitted by flea bites. And it's important because it was the first understanding of how we could characterize a disease. So people who had these specific symptoms all had, quote unquote, Black Death. It's also important because it wiped out between a fifth and a third of the entire population of Europe. So this was a significant issue at the time. During the Renaissance, we had, of course, an expansion in our understanding of mathematics as well as science. And Paracelsus was the first to really found the field of toxicology. And I understand that certain toxins or certain compounds had a target on specific organs. So if somebody was exposed to a specific toxin, it would have a specific impact on a specific organ in the body. And beyond that, that being exposed to more created more damage. So the introduction of the idea of a dose-response relationship, which is still important in epidemiology, understanding um, is there a dose at which below which you're safe and above which the impact is significantly worse. Also, during this time, we have everyone's favorite, John Grant, who really was the first to apply mathematical methods or quantitative methods to looking at disease outcomes. So, understanding risk and risk factors and applying numbers. And so, when you are all upset about how closely tied epidemiology is with biostatistics, you have John Grant to thank for that. He is known as the Columbus of statistics. Believe it or not, that's a good thing. Throughout the 18th century, there was also another expansion of our understanding of medicine and science and therefore public health, which started with Ramazzini, who was the founder of occupational medicine. He authored a number of works looking at the diseases amongst workers. We also have Sir Percival Pott, who was the first to link environmental causes with cancer outcomes. And so he observed that individuals who were working as chimney sweeps, so going in and cleaning out the soot on the chimneys, had a much higher incidence or were more likely to develop scrotal cancer. And so he was the first to recognize that there's some connection between the environment in which we live in and cancer outcomes. And finally, we have in 1796, Edward Jenner, who developed the first smallpox vaccination, which is obviously significant because it led eventually to the eradication of smallpox over 100 years later. In the 19th century, we had John Snow, who is considered the father of epidemiology. Wait, wrong John Snow. This guy. So John Snow was an English anesthesiologist who innovated a lot of the methods of epidemiology that we still use, and he applied them specifically to the study of an outbreak of cholera between 1845 and 1854. So, what is cholera? Well, cholera is a disease that affects your bowels, your gastrointestinal system. It results in severe diarrhea, which leads to dehydration and therefore death. John Snow, being a physician, recognized some factors or was able to describe some patterns that he noted for cholera. One was that it could be communicated from sick people to healthy people. So if you were a healthy person and you were taking care of somebody who was sick, you might develop the disease. But he also noted that people caring for cholera patients didn't always develop the disease. So is this strictly a person-to-person communication, or is there something else? So the other thing that he noted is that people who were not connected to cholera patients, they weren't caring, they had no close contact, were also coming down with the disease, and that particular populations were particularly affected. So coal miners, for instance, had much higher rates. And that, like a lot of infectious diseases that are concentrated in poor communities, this reached beyond the crowded dwellings of the poor. And so he was really interested in trying to figure out what was happening, who was getting sick, where were they getting sick, and what might be the common thread that could be identified as a potential cause. And so the first thing that he did was look at a map. And so what we use now is something called geographic information systems, and it's all computerized. John Snow literally took out a map of London, identified where the water pumps were, where all the buildings were, and then went door to door and determined how many people in each building were getting sick. And so he mapped the residence of people who died in cholera in relation to various potential risk factors, including these water pumps. Remember, this is before individuals had running water in their home, so they would have to go out to the street, use a pump handle, and get their water. And so what he noted was, for example, over here on Broad Street, near the Broad Street pump, there were quite a few deaths due to cholera. Whereas further out here, near Old Compton Street, there was a pump and some deaths. And over here, there was a pump and almost no deaths. And so there's some pattern that seems to be developing. And so this is a replication of his actual map. It's a picture of the map that he used, which compared cholera mortality amongst people using different water sources. And so what we have is in the blue area, this outline area that's blue and then fades down to green over here, this whole area, um, they were served by the water company of Southwark and Vauxhall. Oops, sorry, I didn't mean to go there. And this red area over here was served by the Lambeth Water Company. So they had different water sources. Between 1845 and 1852, both companies supplied water from two people using the River Thames, which was particularly downriver, was very polluted, right? So this is before we had really good modern sanitation. So they were getting their water from the same place that they were dumping garbage and sewage. So not very healthy. In 1852, the Lambeth Water Company, remember that area that was in red, moved their water intake upriver so that they would be getting cleaner water. And then in 1854, there was another cholera epidemic. And so now John Snow could look at, were there differences in water supplied by the Lambeth Waterworks Company and the Southwark and Vauxhall Company in terms of cholera deaths. And this led to what was called the Grand Experiment of 1854. This was the basis of what is considered a natural experiment. So John Snow did not do anything to have an impact. He was simply observing. But there was a circumstances that changed that then allowed him to develop a hypothesis regarding a causal factor and look at differences in a particular group. Right? So he looked at mortality patterns by the water source. And so what he found is that in Southwark and Vauxhall, there were 1,263 deaths from cholera. The Lambeth Water Company, there were 98. The rest of London, there was 1,422. So seems like, oh, okay, so Southwark and Vauxhall and the rest of London, terrible. But it's really important that when we do this, we note the differences in the number of houses. Right? So if we're just looking at the numerator, we're not getting the full story. We have to understand what our denominator is. Again, epidemiology, quantitative science, we need to understand not only who's dying, but who's at risk, who has the potential. And so we actually need another column. And so when we want to understand and normalize and see who's actually getting sick, we take our numbers and we take the number of deaths from cholera, divide it by the number of people at risk. In this case, I'm multiplying by 10,000 in order to just have a number that's easily comparable across the water companies. And we get a number of 315 deaths per every 10,000 houses. Okay. For the Lambeth Company, you do the same thing. So it's 98 deaths per 26,107 houses. We multiply that by 10,000, so we have a standard number that we can compare. And the number's 37. So not surprisingly, it's small. So Southwark and Vauxhall, higher number that matches with the total number of deaths. For the rest of London, however, what we see when we do the division is that there are only 59 cases per 10,000 houses. And so if we were trying to understand who's at greatest risk, we would do it this way. We would calculate the standard incidence rates, or standard mortality rates in this case, and it would appear that individuals who live in areas that get their water supplied by Southwark and Vauxhall are at greatest risk of dying from cholera compared to individuals living in areas supplied by Lambeth or the rest of London. And so John Snow's contributions were that he noted that there was a power of observation and written expression. So simply observing what's happening and noting it is an important first step in epidemiology. He also applied some really now standardized epidemiologic methods. So he used mapping, so spot maps of cases, and then used data tables to describe infectious disease outbreaks. And beyond this, he went another step, which was he took that information to recommend public health measures to then prevent additional cases or other outbreaks. And in this case, He went back to the water pump on Broad Street, which seemed to be causing the most cholera deaths, and he removed the handle. This forced people to go elsewhere to get their water. In doing so, they tended to get water from sources that were less polluted, and we saw the number of cholera deaths drop dramatically. Now, there's a lot of discussion about whether the number of cases were already dwindling at that time, but he also made a number of recommendations. For example, for the coal miners who were down in the coal mines, they were staying there all day. They were eating their lunch day there, and they were also using the bathroom there, so they weren't washing their hands. He made recommendation about housing conditions for people living in poverty to make them healthier so as to reduce the spread of the disease. So these are all important parts of epidemiology that we continue to use today. Also in the 19th century, we had William Farr, who was one of the first to develop a system for understanding medical conditions in a standardized way and looking at case definitions. And so this is sort of our beginning of our medical manual of disease and what counts as which disease versus something else. And also very important to public health was Robert Koch's postulates, which looked at the association between microorganisms and diseases, and really setting a set of sort of rules, or what he called postulates, for what does it mean for exposure or a microorganism to be causal for a disease. And so in thinking about infectious diseases, he came up with his initial 4 postulates. One was that if we want to say that an infectious agent causes a disease, the organism must be observed in every case of the disease. It must be able to be isolated and grown in pure culture. And the pure culture, when inoculated into a susceptible animal, has to be able to reproduce the disease. And then the organism must be observed in and recovered from that experimental animal. So the idea is it has to be there every single time. Now, he realized that these criteria were not fulfilled in the case of cholera, where the organism may be present in humans without causing the disease. And this was later seen as even more of a problem for viral diseases. Later, they were seen to be too rigid, limiting identification of multiple factors that together cause diseases, especially non-communicable diseases. But even for infectious diseases, there are multiple factors, as well as the causative organism. So poverty, lack of nutrition, lack of access to care, and other social inequalities impact not only the incidence of the disease, but even more so the severity of an infectious disease. But this was the beginning. We're just getting started. In the early 20th century, in the beginning of the 1900s, we saw the next big pandemic, which was the Spanish flu. This killed between an estimated 50 to 100 million people worldwide. And some estimates suggest that about 1/3 of the world's population became infected and developed clinically observable disease. So even amongst individuals who didn't necessarily die, almost 1/3 of the population was impacted. Also in the early 20th century, we have the development or the discovery of penicillin, which was one of the most important early antibiotics because it gave us an opportunity to treat people with bacterial infection so that we can reduce the risk of death. And this became available towards the end of World War II. More recently, we have things like the Framingham study, which was the first to really study and identify risk factors for things like coronary heart disease. We have the development of the Epidemic Intelligence Service, which is a governmental agency that is tasked with understanding and responding to epidemics in the United States. In 1964, we had the Surgeon General's report on smoking, which was the first government report to really identify the negative impact of tobacco on health outcomes. And remember back from 1796 or so, when we have Jenner who developed the smallpox vaccine, we now in the 1960s and 1970s finally have the eradication of smallpox both in the United States and then later worldwide. And where we are now, we have the more recent discovery of associations between infectious agents and chronic disease outcomes. So things like human papillomavirus and cervical cancer, and the understanding of a bacteria that increases your risk and can cause peptic ulcers, as well as some of these genetic factors in cancer. And so we have genetic epidemiology as an emerging field. So, what do we study now? I'm an epidemiologist. We study lots of things. We study contemporary health related problems. There are people who study prevention of youth violence, the risks associated with physical activity, the impact of a smoke free campus policies on campus behaviors. And that's something that's happening now at MSU. And so we still study diseases, patterns of diseases over time. And again, going back to this idea of diseases that are endemic, epidemic, and pandemic that underlie a lot of the work we do. It's not all the work we do, but it's a lot of it. And so I've used these terms quite a bit. Endemic simply means the constant presence or the usual presence of a disease or an infectious agent in a particular population given in a particular region. It's the idea that we expect the cold and flu around this time of year. Right? We have cold and flu season. It's not uncommon. An epidemic, however, is when we have more of that disease or more of that agent or more of that behavior than we normally would expect. So when those rates spike, for example. And epidemics and outbreaks tend to be used interchangeably. They're slightly different, but for the purpose of this course, we're going to use them as synonyms. And so we have had a number of epidemics, right? So we still have infectious diseases that have been a concern. We have things like Ebola. So we had an outbreak in West Africa in 2014. There were almost 30,000 cases, and 2 out of every 5 infected people died. So this was had a high, what we call case fatality. If you got the disease, you were very likely to die. So that's, even though there weren't a lot of cases worldwide, high case fatality is something that's we have to be concerned about. Zika is another epidemic that has been studied. So this is a mosquito-borne virus. It can also be sexually transmitted. It can cause infection during pregnancy, which results in adverse birth outcomes like microcephaly. In January 2016, there were about 3,500 cases in Brazil, and there have been local occurrences in the United States, specifically in Florida, where there are higher rates of or higher numbers of mosquitoes due to the climate. And then salmonella. So we've got a number of those. With romaine lettuce pops up every now and then. At one point, they were identified in raw tomatoes. It infected over 1,400 people. It caused 2 suspected deaths. Cases were in 43 states. And so these are still things that we have to study and understand, because in the case of something like tomatoes causing salmonella, epidemiologists recognize when there's an outbreak, what's beyond the normal expectancy, what's beyond the endemic rate, and then identifying the causes of the disease or likely cause so that we can have an impact in terms of having a recall on tomatoes or putting out an announcement not to eat romaine lettuce. Pandemics are similar to epidemics, so it's an epidemic that's worldwide or crossing a very wide area. It crosses international boundaries, and it usually affects a large number of people. So as I mentioned, the 1918 Spanish flu was a pandemic. Right? 50 million deaths worldwide, over 500,000 in the US alone. In 2009, there was another influenza pandemic. This time it was swine flu. Again, it caused almost 100,000 cases, just under 500 deaths. But beyond infectious diseases, we can have pandemics of chronic conditions. So obesity is considered a global pandemic. The rates have increased dramatically over the past 50 years, and the rates of obesity have gone beyond what would be considered typical and spreading worldwide. So there are a number of key characteristics of epidemiology that make epidemiology unique, and I'm going to talk about each of those. So the first is this idea that there is a population focus. So epidemiology looks on the occurrence of diseases throughout populations, and how we can define populations are different. Right? We can look at a population of a town or a state or a county or a nation, or we can look at populations as defined by groups of people with similar characteristics. But either way, there's always the population focus. And this contrasts with clinical medicine because clinical medicine is concerned with the individual. And so while public health is concerned with minimizing adverse collective outcomes, clinical medicine is more concerned with maximizing individual positive outcomes. So taking one person, keeping them as healthy as possible, returning them to good health. Public health wants to minimize negative outcomes for populations as a whole. And so for this reason, it's sometimes referred to as population medicine. Epidemiology is interested in the distribution of disease or health outcomes or health behaviors often in population. And I'm trying to identify or understand why some groups or some subgroups or subpopulations are more frequently affected than others. And what does that mean? And why could that be? Epidemiologists look at determinants of diseases. So what are the biological agents that are causally related to a health condition or other defined characteristic? And we look at exposures. Right? So this can contain either contact with the disease-causing factor, the amount of the factor, and how that impacts on group and individual health. And so again, that amount of the factor referring to the dose-response relationship that was discovered many years ago. And when we have exposures, we talk about outcomes. So in epidemiology, we talk about morbidity, which is illness, and we often talk about mortality. So death from either specific or all causes, or the outcomes can be health behaviors. Right? So what are the policy factors that have an impact on health behaviors, and how do those health behaviors have an impact on morbidity and or mortality? Another key part of or key feature of epidemiology is this reliance on quantification. We count things. We count how many people died of cholera in a particular house. We count how many people were diagnosed with breast cancer last year. And so we use the statistics, we use those counts to understand and describe the occurrence of disease, and then measure the association of that outcome, of the exposure with a particular outcome, so we can better understand where we need to intervene. Epidemiology, as I said, is BFFs with math, is BFF with biostats. It is a quantitative discipline. Epidemiology also works with people in health promotion and health policy to try to alleviate these adverse health outcomes, again, at the population level, to try to prevent disease. So the connection between the smallpox vaccine and smallpox development and understanding that if we vaccinate enough of the population, both domestically and worldwide, we can eradicate the disease. We can actually prevent a disease from starting. And we'll talk later about the levels of prevention. And it informs these policy decisions. And so, again, epidemiology is intricately linked with prevention and control of diseases. And we do this by applying what's called the scientific method. So we use study designs to try to look at these associations, these connections, and we do this through two sort of main branches of scientific study. Descriptive epidemiology, observing, and just sort of characterizing who's getting sick, the distribution, so thinking back to Jon Snow's how many houses, how many deaths, right? That's descriptive epidemiology. Analytic epidemiology is the next step, which is where we develop hypotheses about the associations between exposures and health conditions and try to calculate what those associations are to determine whether something is causal in terms of epidemiology. And so we will be learning about a number of epidemiologic study designs, so ecological, cross-sectional, case-control, cohort, and experimental, and we will be learning how to analyze those data at the very, very basic level. All right, so if you recall, I mentioned we're not doing anything too challenging in terms of math. It's going to be adding, subtracting, multiplying, and dividing. Sometimes you'll need to do more than one thing at a time, though. So we'll brush up on our math skills. Um, in terms of the historical use, um, we look at the, again, patterns over time. And so we can see things like the epidemiologic transition. This idea that we've moved from infectious diseases as the leading causes of death to more chronic diseases. So pneumonia and influenza was the leading cause of death in 1900. It's now down to around number 8 currently in terms of leading causes of death, and it's one of the few infectious causes of diseases in the top 10 causes of death overall. Okay? Whereas things like heart disease and cancer have moved up. Why is this? It's because people aren't dying at younger ages from things like tuberculosis and diarrhea and enteritis, and they're living longer, which allows their bodies to develop other, more chronic diseases. And so if we look at the infectious disease rate, right, so this is the overall crude infectious disease mortality rate from 1900 through about 1996 in this particular slide, you can see that that hasn't been a consistent downward slope. There have been some changes. And so this is due in part to the impact of public health. So initially we had the first continuous municipal use of chlorine in water. So we started cleaning our water, we had better water sanitation, and you saw a drop in infectious diseases. We had the 1918 influenza pandemic, so there's a huge spike in mortality rates. But once that wave ended, once that viral epidemic passed, there was a dramatic decrease. Again, we have the first use of penicillin in World War II, caused another significant decrease in infectious disease mortality rates. The Salk vaccine for polio was introduced, which further decreased mortality rates. And you see that it starts to decrease and level off, except for this very slight increase that started in the late 1980s. This increase, that spike that obviously isn't as high as something like the Spanish flu pandemic, was caused by the global pandemic of HIV and AIDS. And so if we look at this comparison of crude or infectious disease rates, non-infectious disease causes, and all causes in terms of mortality, again, you see this spike. That's the 1918 influenza pandemic. Non-infectious causes have stayed fairly stable. There's been some change, but pretty stable. But we've seen this dramatic decrease in infectious disease causes. And so all-cause mortality has gone down significantly. And because of this, we have the epidemiologic transition from infectious to chronic diseases that has resulted in a demographic transition. So this change from high birth rates and death rates to much lower birth and death rates. So in the pre-modern era, we had high birth rates, but also high death rates. And therefore, we had a relatively low population. We then have a drop in death rates, which caused a significant increase in the total population because birth rates stayed stable, but fewer people were dying. And in the mature industrial and post-industrial eras or stages, what we've had is a stabilization of the total population because now we have lower birth rates, but we also have relatively low death rates. We don't know what's coming in stage 5. What I will say is that we've actually seen another beginning of a drop-off in birth rates. So people are having fewer children. So you can see that the total population is also starting to decrease. But this transition has also caused a change from the sort of population as a pyramid with a high number of very young people and a very small number of people, 70 and above, to a pillar where we actually have quite a few women who are living to 85 plus years of age. And that has an impact and is going to shape health outcomes, but also resource allocation. And so this is what's driving a lot of the conversation now in terms of health policy about how do we pay for healthcare. Our healthcare system was really based on the idea in 1960 that very few people were going to live past 65. And so if we supply Medicare, for example, healthcare for everybody over 65, there won't be very many people who were alive. That has changed. And so what we need to understand now, and what a big push in public health is in terms of healthcare, is rather than treating people with diseases, we need to shift our focus really to primary prevention. How do we keep people healthier longer so that they stay out of the healthcare system? Epidemiology is used in communities to really understand who's getting sick and, again, how to then allocate those resources in terms of our health services use. So, how do we study the workings of health services to view their improvement? And again, this is very important in terms of health systems management, in terms of how do we ensure the best access to the best care for the most people for the best outcomes. So this is a large and growing field. And so we look at how do we optimize utilization of healthcare services? How can epidemiologists provide quantitative information about availability and cost? And we help in planners to determine what services are going to be needed in which communities and which services are duplicated unnecessarily. So we don't want 3 different agencies providing the same service and another when there's a whole nother area that's not even being addressed. So how can we be more efficient? And we can apply these epidemiologic and quantitative information in order to achieve those goals. Epidemiology looks at estimates from the group experience to what individual risks are and estimate the chance of avoiding them. And so we do this by looking at things called risk factors, right? So it's an exposure that's associated with disease, morbidity, mortality, some adverse health outcome. And we calculate this by doing a methodology of risk assessment. So trying to use numbers again to calculate risk. And at the end of the day, we're very interested in understanding the root cause of the disease. And so we use those quantitative and observational methods to compute experiences from the groups based on composition, inheritance, experience, behavior, and other environments. And then we can reduce healthcare cost by providing integrated care for chronic conditions based on things that we know have either similar risk factors, or through the application of epidemiology, we understand how they're connected. So we know that heart disease is one of the leading causes of death. It's overall the leading cause of death in the United States. And we know that heart disease is increased, or heart disease risk is increased amongst people who have diabetes. Diabetes is a microvascular disease. Diabetes, one of the root causes is obesity. Obesity is also related to heart disease. And so if we can address obesity, we can reduce both diabetes and heart disease potentially. Right? And so looking at how do we integrate care for diseases that tend to cluster together. Overall, epidemiology is a science, but it's also an art. Right? People who train in epidemiology have to take this multidisciplinary or interdisciplinary approach. You have to have some understanding of the science, but you also have to understand human behavior, you have to understand mathematics, you have to apply law and policy, and so they all come together through this field of epidemiology. We use that in the scientific method. That scientific method can then be applied to multiple studies, whether it's health related or not. Epidemiology, and hopefully this course, will also help you develop your critical thinking ability. And so really not just looking at the numbers, but thinking about what do those numbers mean, what's left out, what can we study, and what's harder to study, and how do we get at that. It uses these quantitative methods, so mathematics, as well as more and more reliance on computerized statistical methodology and things like geographic information systems. So, using these online maps to develop a better understanding of who's getting sick and where these concentrated areas of concern are. Epidemiology requires you to develop and utilize your communication skills, because if you find out who's sick, you have to be able to communicate that in a way that's meaningful and understandable to lay audiences. And so, at the very least, out of this class, I'd like you to be able to read, critically understand, and think about epidemiology and research articles, and then be able to communicate those in ways that other people can understand. And so, whether you're interested in going into community health education, where you're translating research for lay audiences, or health systems administration and policy, where you're translating the research for people who don't have a background in health but do have an impact on policy.